Gives me great pleasure to introduce our next speaker, Dr. Nicholas Myers. Has been practicing for 29 years. The bulk of that time he's been in some way involved in holistic dentistry. He practices in Scottsdale, Arizona, and was the second private practice in the United States, in Arizona, okay, to have a Galileos installed. I think I'm the third. I'm not sure. Anyway, this morning he will be giving an overview of the menus and inner workings of the software. There's an opportunity to play with the software yourself with the installation to help your laptops. What's unique with the Sirona Galileo is your patient, your client, will get a CD from the imaging center that has its own workable software where the person can take the image and play with it and get it to go in and out, which Nick is going to show you. You cannot do that with an iCat. You cannot do that with any of the other 3D cone technologies. It's my pleasure to introduce Dr. Myers.
Is everyone here familiar with the cone beam technology that's currently on the market? iCat, Galileos, or UTOM? Not too much? There's one. A few years ago, the Academy had Dr. Chris Simmons from Seattle, Washington, and he gave us a presentation on the UTOM technology, which was an Italian machine. Wonderful images. The major problem with that was that you could only view those images on the machine that it was acquired from unless you made a photographic copy and then printed hard copy. One of the nice things now about the, as Mike was saying, the Galileos imaging system from Sirona, and by the way, I don't get any money from Galileos or Sirona. I am simply a customer. The request was made by Dawn because of conversations that sometimes people will get a disc to their office and you can't pull an image unless you know what to do with it. And the intention of our program today is how to work with some of the software features, and so that when you get a disc, you'll be able to do something with it through what's called a reader program. The reader program is not a full-blown version, but it will allow the individual doctor or practitioner to take a look at the images and have some basic manipulation and viewing capability. As you'll see as we go by, there's some very neat features regarding nerve mapping for the mandibular canal, and also for those that place dental implants, it's got a very neat slick feature of being able to place an implant of various sizes, shapes, as well as designs into the actual position where you're looking for. And you can play with that based on what your parameters are for implant placement. I'm not really drunk with this little picture. So, with that as a background, this is my first time presenting this material. I was hoping simply to impart a hands-on workshop experience. That's not going to be able to be fully functional. I have only one laptop. I can't put my program onto other computers because I don't know how to do it, although that can be done. My computer guy was left at the dock. He got a plane late, taxi late, and he was left standing at the docks when we were sailing away. So I've got it all on my little thing here, but I don't know how to load it. So sorry for that. So we will be able to play. If you want to have some hands-on yourself, it is functional on my laptop, but unfortunately I know that there were some laptops, I know Bill had brought one, that wanted to have the ability to use the software and play with it themselves later on. So the purpose, again, to orient participants to using the 3D radiographic images and to enable you to have a hands-on experience. We're going to have a limited hands-on experience, but you will have a good flavor of how to negotiate, how to get around the software. Basically, this is the format that I'm going to follow. We're going to discuss the initial screen view menus, iconic meanings, which all the little icons along the sidebars, and menu, the stepwise flow to useful data. It's one of the things that you get all this stuff, you don't know how to get around and negotiate inside the software until you start having well, how am I going to use this? When I first got this about 4 months ago, I would sit and I would be mesmerized for hours just learning how to go around and do all this stuff. And it soon became apparent, like in the first hour or two, that this was not going to work unless I had some structured way. And you can imagine having kind of being on the cutting edge of this that you don't have, unless you have a mindset of how you want to do that, you'll be just like I was and floundering around and being marveled about it. We're going to explore basic imaging, nerve mapping, as well as implant placement. The working software that I have here is what's called a reader. We'll be able to look at things, but we won't be able to actually do nerve mapping hands-on. I have it on structured sequence and flow, how you would do that if you had the actual software. So I have kind of 2 tiers of programming. The IABDM. This is what the Galileos unit looks like. It's just a little bit bigger than a panoramic unit that you would see in your office. The footprint is probably about 6 inches larger all the way around from a standard unit. It's got a little touch pad you can see on the side. What you can't see, what you will see, is the range center. So the person would be, it's a stand-up unit. They just grasp the 2 handles here, and the machine goes around the head. It takes 14 seconds to do a scan of 200 images. And it sounds like, since it's made in Germany, I was kind of joke when we first got it. You can hear all the little mice going around as the images are being captured. The future's here, and it's wonderful. Now, I like non sequitur comics also, so I went and fetched this out after I saw Boyd say, "Trust me, it's just what we call an alternative means of dentistry." Perhaps you've seen that. It's not your grandpa's dentistry. Modern dentistry, think about it, what we have available today is not what our parents' generation had to work with when it was really just, say, mercury fillings and regular plain film dental x-rays, and the airspeed turbines were just coming in the 50s. So before that, it's really dark ages, much like that last picture. One of the things that I found in the saga of implementing this technology, as well as other electronic technologies, into the practice, is that you need a lot of room for more boxes that contain more stuff that makes your life a bit more complicated. Now, if you've started implementing the small digital radiography or the cameras, you know you're getting more stuff. You put some lasers into your treatment rooms, you get more boxes. So the traditional small dental operatory that we all grew up with doesn't work anymore. You need to have a lot more room. This is now in a separate room. It was an operatory, which we turned it into a storeroom, and one area of it's now dedicated simply for technology. And there's another computer down below here that I didn't want to stick it over on this side of the mishmash. So what we have in our room here, which I really couldn't get a good picture of because it's not that big of a room, you've got a desk, which is a small student-sized desk. It's 4 foot by about 2.5 feet in depth. Adjacent to this, so you got the bank of computers. You got to have phone contact. You got to have some source of telephonic communication, because you're going to be on support, especially in the early times, quite a lot, getting things ironed out, as Mike is finding out. So you need to have a good access to phone, and unless you can make sure that when you're doing things like this that you've got really a dedicated IT guy to start you on a good path, you're going to be floundering. Do not attempt this yourself. Do not. My IT guy, as I said, he had plans on being here. He was going to help get all these installed on laptops, and some guys, you love them for who they are, and you just kind of miss the boat. One of the benefits, as you know, with 3D radiography is that you can have the images. This is very slick in that you can portray all three dimensions simultaneously on one screen. You've got a skull view that shows you in the little window off that you can see right here where your object of focus is. That what you're seeing in yellow is represented here. This is called a slicing window. The slicing window has a T or a cross T in it, which is for your purposes to orient you on every one of these images. So you're having a small image here, basically of this. So the crosshair tells you where you are. You're right over that impacted cuspid.
Can I turn the
And
lights
now
down?
you're seeing on
So
these
they can
other
see
images.
Turn the lights down.
Sorry. Oh, much better.
Much better.
So what you're seeing over here then are these other images. You have a sagittal view here, and then you have a frontal view. And then if you look carefully in the slicing window, we'll see this again. There are two lines. You have a major cross piece and then two separate lines up at the top. Those are windows of 5 millimeters to the left or to the right. So that gives you a view down below here. This cross T is 5 millimeters to the left of this central. So that T, that cross is right there. And then this is 5 millimeters to the right. So it helps orient you. Now the screen off to the bottom left here is the slice right through here and this way. You have this cross T now is represented in a whole different way. So as it helps keep you oriented, and you'll see this, the importance of this as time goes by, because you can, especially early on, you get so lost in where are you? Where are you? Where am I? I'm on the ship. The nice thing about this system is that you can take your mouse cursor, and we'll be able to play with this, and this little cross hair here, you can put that right on the center of that and move that wherever you want to. So if you want to take that in any one of these images, you can center your crosshair and move it left, right, up, down, or over on this one, you can move it all the way around the jaw. It's moving every one of those images simultaneously, so it's almost like watching a motion picture. It causes you to have to think differently. You're now thinking three-dimensionally rather than just in two dimensions and having to interpret. So that added dimension of view that you have is awakening a part of your brain that you really haven't had to access a whole lot. It's the unknown zone. But this is some of the neat things that you can get. One of the things that we have done in the practice right from the very beginning now is, if you notice this particular image is a bit of an open mouth view. Traditionally with a panoramic picture, you're asked to take a bite stick and put it between the incisors and then capture the image that way. What we've done by design is to have a central occlusion image capture. I want to see how the condyles are being seated in the fossa right from the very beginning, because I've been treating TMJ problems for a long time, and that's one of the basic positions that we start from. So that's what we do. I'm not saying if it's right or wrong, it's just it becomes very handy for me to just it's been one of the first things that I always look at. Right now, what I'm going to do with this next little segment is simply talk about some of the images and what we're looking at, how we look at them, to help orient you with this, because everybody's going to be at a little different place in their thinking process, the thought process around it, and I'll help orient you. You see okay? No. That better? Sorry. All right. So as I mentioned, this is when the image first comes up and is reconstructed, you get a panoramic image. So then you can take your slicing window, move it wherever you want to, whatever the object of your attention is. Right now, I've got it centered over the right TMJ. If you call your attention down here to this image on the bottom right, you can see the orientation of the grid is right through the head of the condyle, so that now you have an opportunity to see where it is on the condylar head. You see where it is here in this cross-sectional view, and then the tangential view here. So just pause and take a moment and get that thinking in your head. Now, I have to also say, the heavy white banded line, everything has some significance. The heavy banded line, you can take your cursor and shrink or expand the images. So if you wanted it, and we'll again do this in a playing way, I can take that line, put my cursor here, and scoot it up. I can make that Panorex once I've identified where I want to go, and shrink it at the same time, simultaneously expanding these images. So I can take a little tiny image that, say, is 2 inches by 2.5 inches, and make it 6 inches by 4 inches or something. Additionally, then the sidebar here, I can take that, expand it over here, and make that a much wider image, so I have a much larger plane of view. Similarly, when I do that, or concurrently, I will shrink this 5mm window. I can shrink it to nothing. I can make this central view bigger, and then I can shrink the 5mm on this side, the other half of that, out of the way. So then I'm looking right very precisely at just exactly where I'm at, and I know that for that jaw, then I am precisely here, and I can magnify that. Another nice benefit of this is, and again we'll look at this, is that sometimes, depending on head position and the size of the head of the individual, you might be just a little bit outside of the actual cone, the area of interest with the joint. So because it's somebody may be too big for that one image. It's about the size of a volleyball. The cone is what you can see right here. This is how they come up with the term cone beam. So it's just that area that we are looking at. If that person's head is too big or they're positioned poorly inside the holder, you'll start to cover up, or you won't be able to fully see that particular part of the images, the object of your attention. If that occurs, just kind of turn the lights on. Put your cursor where you want it. Then you can come over here to your contrast and your brightness buttons, and you can enhance that area of the image and draw out the information that you otherwise would have lost. So it's kind of like having one of those little bright spots that you have. If you remember, you have a dark X-ray, you get that, go into a dark room with a little bright spotlight, and you now see the image, the information that's on the film. Well, this is the digital way to that analog process. The panoramic reconstruction. And this is the first image that comes off of the Galileos once it's gone through its reconstruction process. I mentioned it's a 14-second scan to do the whole thing. It's about a 7-minute reconstruction once the image has been taken. So from the time the person stopped to the time the image is now fully loaded into the computer and digested and spun around, and all the little electrons are able to spit out an image, it's about 7 minutes. From that point, then it's about another 2 minutes before the computer where you're sitting calling up the reconstructed image can actually load all the data. I'll give you an example. My little laptop here is older technology, and it took about 5 minutes to load an image like that from the disk that I brought. So it's a slow process depending on the horsepower that your computers have. So I've learned a lot about hardware and software the hard way. Most often, initially, just to get the bird's eye view of an image, what we'll do is we'll put the slicing window off to the side. You'll see what happens later on. It distorts the image because that allows, when you have that, wherever that is focused, you've got one tiny little point of focus, And everything 5 millimeters in front and more and 5 millimeters off, they're going to be well out of focus. It's like dialing in a microscope with a fine tune compared to the gross turning dial on it. Would you agree this is a pretty nice reconstruction for Panorex? I'm going to show you though, as nice as it is, there's something that's missing, which is why I write here what's hidden. The next image, I put the slicing window over the second molar right here. We can see a very large lesion. Take a look again. You get a little hint. There's something down there. Sorry?
Always after you've seen it.
It's always after you've seen it. You've got 20/20 hindsight. But that's quite a large image. Now, this is what I was showing or mentioning earlier. You're able to shrink that upper window and expand these others. So I've totally taken away the minus 5 millimeter window. I've just closed it up and blowing up that one area. So we're seeing this is the gross orientation. Now we can zoom in and see very precisely an area. And then over on the axial gets equally blown up by this orientation. It shows you where you are relative to that crosshair. Here's your crosshair here and here. So that's right down that spot. Clear as mud, isn't it? I call this one a sneaky lesion. We're just doing a potpourri of some lesions to get a flavor, to get your mind thinking about this before we go into the screens. This is another really nice reconstruction. I'll show you one of the pitfalls of metals. This woman happened to wear an earring on her left ear. The way the image is taken, it's all this little wavy stuff is from that one earring. It just distorts the image all the way through. It's just kind of a crazy thing. Depending on the precious metal status of the crown and basically the KVP that you're dialing into sonically like a conventional pano, you could have more or less scatter off of your crowns or bridges, dental implants that you'll see. You'll also have that kind of waviness. Not always, sometimes, I don't know. So let's go back. Here we have this nice root canal tooth. I'm going to bring the slicing window over the top of it. So now we have a much more precise ability to go, not just by, say, a millimeter slice at a time. You can go to about 1/4 millimeter movement on each one of these pictures by moving your mouse very precisely. So we start to see a lesion popping up here, down at the apex. Here's the same picture now, that we're looking at it from this picture that we just saw here on the bottom left. Now this is the cross-sectional view. So basically, right now, if you're looking, you can look at me and you're looking at me straight on like we would see in that tangential view. That cross-sectional view is if you're turning it sideways. So here we have the ability to see simultaneously that orientation view of what's going on with this tooth. So what do we see? I call this a sneaky lesion. And Michael asked me about cavitations earlier, and you can see right behind that tooth a large lesion that you couldn't see because it was totally blocked.
Nick, well, you're probably going to do this, but if you point out on the right, show the slice that comes, no, to the right, all the way over the head. That one line, you know where it is, you can move back and forth. Tell them how you're focusing that, because you're doing a great job. That one right there.
Yeah, we're going to be playing with that whole aspect of that with live software.
Oh, okay.
You can see the scatter coming off of, since he pointed this image out, the scatter that you can see from the earring when the image was being captured, just really puts it as very much of a distraction in there. Something else to point out on this image is that you can see very precisely the exit of the mandibular canal to the mental foramen here, which becomes a very much handiness when you're starting to do the nerve mapping. What else? One of the things when you're looking at this, and I don't have this particular picture to do the playing with, is that when you're, as Michael was saying, for instance, right now that tooth doesn't look like it's very well filled with the root canal filling material. I'm not saying root canals are bad or good, it's just on this image, she's got a root canal. Because of the ability to move that picture, you can see the curves within the canal. You can see the whole density of that filling material within the tooth. You can see the extra canal that she's got coming off the base of that tooth that wasn't filled as you start moving around there. You might be getting the sense now that you could spend a lot of time doing these things as you're really starting to look at this, and yeah, you do. You end up spending a lot of time starting to look at things that you haven't seen before. And I marvel at it. It's just like, God. Nerve and implant rendering. This is an early rendition of my attempt at using this part of the software. I got a little smoother. You can see that nerve is a lot smoother. This is obviously a missing tooth with a computer simulated generic implant dropped into the slot. One of the neat things about that is that you can see the little halo around it. It gives you a 2 millimeter buffer zone of your safety zone from the bottom of the implant to where your vital structures are. Feel free to comment on any of these images if you have any particular questions as I go through these. These are just what I'm trying to show right now, again, to get you a little flavor of some of the things that we're going to be able to look at. When we're looking at this to start, the image that you're seeing of the implant has the ability to be placed and rotated, and once that implant is rotated, you hit another button and it corrects anatomically the positioning of the structures of the mouth relative to that implant. So it's really interesting to see how that all starts to play and happens in front of your eye. Again, as you move through with the slicing windows, you would move through where the implant, not the implant, but the mandibular canal is. You'll see this little tiny worm device coming and going. As you're going through such little areas, as it's winding its way through the jaw, you'll see just a little snippet. For instance, in this bottom window here, you're seeing just a little tiny area. This is the composite view on the upper, so you're able to see the whole thing, but in the lower, you're seeing just one little spot. On the cross-sectional view, you're seeing just a small little cross-sectional area of I think that was about a 1.5 millimeter target. The computer will automatically size what the canal is once you tell it where the hole is. It somehow reads the differences in density, and it gives you the opportunity then it will make the correction. So instead of a 1 millimeter nerve canal, it may end up being a 1.5 or a 2, depending on where it reads the density differences. Another aspect of this is you see the skull view. You can dial in various density changes within the skull. You can have a transparent skull where all the bony structure totally disappears, and you're left simply with the objects that you've placed. For instance, the canal, mandibular canal, and then the dental implant. You can put in you want a mild transparency, where you'll get some of this, and then you can get a maximum density or opaqueness. You can actually put in the total face of the individual as it's reading the soft tissue density. And then one click at a time in the mouse, you can start peeling back the layers of skin. You'll get down to the different layers of teeth, and it's pretty remarkable. Another one of the, I was mentioning sliding your screens from different places. In a view called radiology, you're getting a coronal view, axial view. Here's your three-dimensional view on the upper right. I've expanded one screen. Here's the view of the left. Basically it's a cephalogram type picture, lateral ceph. And I'm centered right over the atlas and axis. There's my crosshair, as you can see. That is exactly corresponding to that. Every one of the scales that you see in the image is tied exactly correspondingly to the image, so that as it expands, the scale expands along with it, so you can do very precise measurements of the structures using this particular, this is your measuring scale over here. And so you could just measure from here to here if you want to measure that. But one of the things that is interesting when you're looking at structures within the neck for bite problems and that, and when to refer or not, I can't make much of a diagnosis here, not at all. I can see that that's not balanced. That's enough of an issue, recommendation for me to say you need a cranial osteopath, you need to see a cranial sacral therapist, you need a chiropractor, but there's something going on in this neck that needs attention, structurally, skeletally, and people can see this. And then if you look at this half of this vertebrae, it's quite large and long. This one is about not quite half the size of that, which simply indicates that is rotated on the occiput. This is the occiput here. There's a lot to this that I'm learning still myself. This is the first screen that pops up when we go into this radiology view after we're kind of working through the screens on the bottom. If you see it says panoramic with 3D. This is the 3D rendition. The panoramic is what we've seen before without this little guy here. Implant aligned, we have the implant showing the alignment or orientation of the implant within it. The lateral ceph is essentially this picture, but only this picture on the screen. And the radiology view is these four particular images, which I showed you on this slide. I've shrunk a couple of the images. This slide is how it first comes up. And you can just take that cursor right on that crosshair and go ride the airway, and you can look down and see what the shape of the airway is from top to bottom. This is an indication or an image of showing you the soft tissue rendition that the computer is reconstructing for the face of the person. And this little S, P, and L, the little guy there, you can just rotate that and get a total image. You can rotate that head around. If you've had CIREC, this is a similar head. You can click on any one of these orientations in that head. The click of a button will go looking inferiorly or looking superiorly. So you get a bird's eye view. I don't use this that often. It's more for show and tell. But this is a valuable picture. This is a very valuable picture. One of the things when you're, again, I can't do it on these still images, but we'll be taking the mouse, going inside here, clicking on the image, and then we'll be going laterally from the right side of the head to the left side of the head along that one plane, and just you'll start to see teeth coming into position as you're slicing through them, going out of position along the sidewall. Buccal teeth, you can barely see them here. You get to the anterior teeth, and then all the way over to the opposite side of the mouth. I want you to take a moment and look at this image and see if you can find my hidden limit, the hidden image, the hidden lesion in this image. Pardon? I can't hear you. second tooth. This is not a toothy problem.
Distal root of 30, is that obstructed?
There's a problem over here. You said the sinuses, nasal cavity. What about it? The septum of the cavity? Yeah. It's very obstructed. It's got a deviated septum there. Anybody else? This is kind of this one sent shivers up and down my spine the first time I saw it.
You've got the calcification underneath 2021, it looks like there.
A calcification down here.
It's something, there's a lesion there.
Yeah, there is something there. We've got the mandibular canal that comes out there.
Distal of 30 is abscessed.
Yeah,
Distal root of 30 is abscessed.
he's got problems. The thing that those dental things don't scare you too much because you're dentists and we're all dentists and we're used to looking for teeth problems. But I found this in the left antrum, large cystic mass. So let's go back, see where we are. Okay, go back one more time. Here's where we are, right here. That's the lesion. Became a big discussion a few months ago. I had the advanced training for this class is how much information are we responsible for when we take these kind of images as a dentist? And the simple answer was all of it. So it's kind of cute. There was a dentist from Canada that had bought one of these units and kind of thought that was the case, but he figured if he only charged the fee for a Panorex, he would only be responsible for the kind of information a Panorex would give you. Well, it was very, very easily shot down, so we're responsible for all the information.
Don't you have to have a background to be able to interpret that? In other words, you're not a radiologist.
You're not a radiologist. If you see something, I can't say what this is.
We're
for
supposed to be
instance.
doctors of the head and neck.
You're doctors of the head and neck.
We're responsible for everything above the bottom.
If you identify by taking this image, and if you're not looking at something, fortunately in dentistry, we miss things all the times and it's not a big issue. But if push came to shove in a court, and that was, say, a cancer, and you didn't see it, and you didn't, well, if you saw it and didn't tell them is one thing, but if you didn't see it, and that one's pretty obvious, then you're on the hook for negligence, professional negligence. There are services that are available that you can take that image or that disc, send it to a board-certified radiologist or maxillofacial radiologist and get a report for about $125, $150, and your butt is covered if you feel you'd like to do that. That service is available. All the services, the freestanding labs that we have in our areas that offer these, like iCAD images or some of the other X-ray services, they'll send off if you want to send to one of the universities, for instance, and they'll send you back a nice report, page-and-a-half report. One of the things I found out is going through this training is that the nasal cavity is highly variable. They look like jigsaw puzzles, and they're all normal. And the more I'm seeing that, the more I'm watching it, the more I'm getting comfortable with the huge variety of shapes and sizes of turbinates that people have in their noses. One of the things, this is the lesion now, easy, three-dimensional orientation of where exactly is the lesion. So we can see it's on the front wall of the antrum. It's hanging from the top, and here's it in this sagittal view. So you can take this one image, do a screen capture, and email it to the patient. You can send that to an ENT. You can send it to somebody, but you want to take that and I'm not responsible for doing anything about that other than notifying the patient and making a proper referral, because I can't treat it. If he's going to have that treated. I showed this to an ENT, and he looked at it, he says, oh, that's a mucus retention cyst. So I breathed a sigh of relief. I sent this off to I had sent this picture actually to the person who owns this, and said, here, go see somebody. You need to see an ENT of your choice. Now you talked about the sinus cavity. Here's looking right through it. Look at the hypertrophy of the right side compared to the left side of the turbinates. And these things are hugely different. So when I don't get goosebumps up and down my spine anymore with that one, but that was an amazing discovery. So that's 12.25 centimeters across in one direction. You could conceivably measure that in every which way and see what size that ball is, how big the actual volume is. So, pretty remarkable. The other thing, looking at this, is one of the reasons that I actually wanted to use this technology, getting into the study of airways, is looking at tongue position and how compromised the airway is. When you're treating people with these problems of obstructive sleep apnea and snoring and that, you want to know what kind of structure you're dealing with, and this suits that particular goal perfectly. Now, down the rabbit's hole, I call this, how to negotiate the software. This is a Windows-based software. Most of everybody here is probably some Windows-based technology on your computer. Even those with the Apple computers it's a Windows-based. It's a window type of thing, but not a DOS-based. But we're going to be looking at the drop-down menus and the sidebar menus. When the software first opens up, this screen pops up. This happens to be me. The screen to orient you. Don't forget that. You may have a problem with that orientation. You should be all right. Okay, when the image first comes up and you're opening up the patient, this is the screen that shows up. And we're going to look at these different drop-down menus. It says exam, image, edit, analysis, view, utilities, and help. We're just going to look at these one at a time. This is not highbrow stuff. This is very basic. This image, when it comes up, they all come up this way. This little, to orient you here, it gives you the date of the scan, the time of the scan. It says view exam, and then the date again. You have the opportunity when it's first coming up to put in the kind of exam it is. For instance, an initial exam or an implant exam, whatever you want to call it, that will first come up here to give you the visual cue of what exam that you're actually looking at. We're going to look at the drop downs. So the patient, steps, new, select, close, save as. This is one of the ways, and Serona's kind of nifty in that they have about 3 or 4 different ways to find the same information, from little hotkeys to other, there's like 2 or 3 or 4 ways sometimes of getting to the same bit of information. But the drop-down menu shows the patient, so you would go in here and open up a screen that would show you who are you looking for. They're all listed by date. You can toggle back and forth either from the first date on down or from the last date backwards. There's a small window that you would just type in. If you know the person's name, you can go hunting that way, just looking for the name and hitting the enter button and bringing it forward. So that we're just identifying the patient. For new, that would give you something. I don't know. Some of these I don't use. I don't because of the.
It gives you a menu box with name, address, and ID for the patient.
Yes.
Yeah. So. Yeah.
I'm sorry.
It gives you a menu box.
It gives all these will give you other additional menu boxes.
Just name, date of birth.
I'll show a few of those later on the when it comes to the implant one that you can't barely see off the side of the screen there. from the image, because the software can handle more than just the three-dimensional image, you'll have choices from storage of intraoral x-rays or panoramic x-rays. You can go from scanning if you have a scan that comes from somebody's office, if you have an email scan that wants to come in and that you want to put it into the software, you can do that. I haven't done that yet, so I can't really comment much about it. Print preview, email, import, export. These buttons, or these features here, are on the sidebar over here that we'll be looking at in a little bit. The edit, we can copy, paste, and remove simple things that you would have with any kind of a paint program. Adobe Photoshop. Again, simple tools for analysis. Most of these here that are here, mouse adjust, select, the hand, they're going to be over here on the sidebar to the right. So you have much more quick ways of getting around than having to do 2 clicks of a mouse rather than just 1 click.
Nick, we changed. Okay, you're recording, so you better not show them.
Okay. All right, so on the view, again, the image, magnifier, 3D. This little 3D is critical. It also resides right here. So we don't have to use the drop-down menu. There's a lot of redundancies, kind of like a NASA shot to the moon. So different ways of getting around the system. The next one is our utilities, which I've never even had to use these. I can't comment about any of these. And then the help menu, which is a typical Windows feature. It allows you to get into the help dictionary if you get lost and you don't know what you're doing, which in the early times of playing with the program, you can do that pretty easily. Now we're going to look at the sidebar menus. That was the top, and these are single-click icons now instead of the double clicks going through the menu, having to search. If you know what these, the first one, that you can see over here on the side, a little down arrow. It's a down arrow with a little up arrow. It's to select the image. So this is the screen that would pop up, and then you would just simply click what it is that you want. Do you want to carry the whole thing into your image, or do you just want a particular single scan? So you have the opportunity to do multiple image captures. When you do those, they'll go storing at this one screen. So right now, this is the only ones that are on this particular client. The next button that I have showing is a closed image, and I don't know if I can. This is, no, we're stuck with what we've got. This is simply to close the image. This is the same the same button as that you would have up in the little X up in the upper right-hand corner of your screen. It closes the image down. The next one, I should have gone there. There we go. Print image. It's a little icon of a printer. So all you have to do is hit that button, and whatever your screen is, it will print that one image, goes right into your print menu, and you can tell how many images you want. Again, like most x-rays, when you're printing them, photo quality paper gives you the best rendition. If you use just plain paper like you have all of our paperwork is on, the images don't come out very well at all as far as their quality. And even I've tried some ultra white bright paper, trying to make that bridge between regular paper and the photo glossy kind of cardstock paper. It's a little bit better, but still the best images are on the photo glossy paper, bar none. So you hit the print image, brings you just to your conventional printer screen. Exit program, it's self-explanatory. So these are just the single buttons over on the side. I think the implant one is next, yes. There's a little shape of an implant. I'm sorry you can't see it on this screen. We're getting kind of chopped off with the projector. But this is a really slick feature. There are probably three dozen different dental implants by manufacturer and size that are in that sub menu right there. So you can just go down right through it. There's this little slider bar, and you can pick your implant. This is the Frident. You can insert it wherever you're looking. So these are the side buttons that we can look at. this is what, if, for instance, one of the things that we're doing now, because this is a wonderful tool of a machine to be used in your practices, we've turned it into a profit center. We're offering to doctors in the area the use of the Galileos to have scans made of their patients, and they can get an image. We will use this. We take the image, this button here, it's called the Rapid Go, and that will take their images that we just scanned and put them onto a DVD. Very fast, very simple. The patient will take that DVD to the referring doctor that has reader software, and then they would put it into their computer and use the next button, which is import DICOM media. So we have the export screen, which takes the data from our computer, puts it on the disk, they go out to their doctor. The doctor gets it, sticks it into their laptop or their desktop, as long as it's got enough horsepower. And then they can manipulate the images as we're going to be showing. The thing that they can't do is do implant placement and nerve mapping. That's not part of the export feature. You need a fully functioning program in order to do that. So there's our import. Now, I mentioned about the 3D. For whatever reason, the screen capture didn't do it. You know the little hands that point to where you're wanting to go, and you click the button because that's where the hand is. That's where you would go here, and this is what we do. The little hand points to that one, then you click the mouse, and then it takes you from this screen into the Galileos screen, the Lexis software. There's really two software programs that are part of the system, the Synexis, which is the initial capturing program, and then the Galexis, which is the 3D imaging manipulation software, and the Galileos is the name of the machine. I'm trying to keep all that straight as crazy. So when you first click that 3D button, this screen pops up, and this is where it takes about 2 minutes of time. You're just waiting, making small chat with the patient if you're waiting for them. But it just goes through this little screen. The next screen shows the loading of the panoramic. Again, this whole process takes about 2 minutes. This part is a little bit less time consuming than the first part that I just showed you. So as it's compiling all the data, different images will start to pop up at different times. So we're at 66% completion here. And you'll notice that the slicing window is right on the front teeth. So it looks like it's a fish mouth right now. I mentioned we take all the images with our teeth in closed position, so you really can't have a fish mouth. But until you realize that this is just a very small little cut through one part, and it's not from the front of the teeth, it's somewhere around the bicuspids. The cuspids, if you can see here. So those other teeth are just out of focus. In fact, here's where we are. We're behind and up behind the upper incisors. This is the lateral, the central, and the other central. I'm sitting right here on number 8. Again, this little image that you see off to on the bottom right orients you where you are on the dental arch. You can put your cursor on that little grid and just drag it around, and all those images will change simultaneously. Depending on the speed of the graphics card, and this is we learned kind of the hard way, is that if we had a slow graphics card in one computer, and there would be a terrible delay. So you'd be wanting to move that mouse over, and it's not moving because the graphics card can't process all this volume of information. I showed you earlier that mishmash of computers on the one shelf. One of those boxes, the smaller one to the right, was simply the memory unit that goes along with this. So it does everything with what are called terabytes. Huge volumes of information are being generated now that go into this system. That, years ago, you thought my first computer of 20 megabytes. I thought, oh God, I'll never max this computer. I'll have it for years and years. And then about 2 years' time, there was no more memory available, and then went that computer, got the next one, and on, and the rest is history. What we do, once that image comes off that you just saw, we have to align it. The alignment process is real simple, and it goes through this, the buttons change up at the top. You have to go through the analysis. go to the panoramic view, and what we will be doing is that we align the, I think I've got it. We would align with the lower incisors the orientation. So you're taking into account at this time the size and the shape of the volume that you're wanting to capture, and that will be in focus in all of those cuts. You can select 3 different jaw sizes as the basics. Then you can take and create different percentages of the volume. So it starts out, say, at 150% of normal volume. You might have a big window, you say, well, I can tighten that down. The tighter down it make it, the more clear your images will ultimately be for your diagnostics. So once the image has been set, this is what you get. It comes right to the center, and then you can start moving all the way around. Again, this is what I was indicating earlier. I had this is a part of the mandibular canal. It's really neat when you're mapping that, and I'll show you that. So I'll say that how we do that. To help orient you again, this is the slicing window with its, if you imagine the center part like I am, is the center. My left hand is 5 millimeters to the left, and the right hand would be 5 millimeters to the right. That's why you have this little way it looks there. It's like a little wedge. This is pretty much the same. Oh, what I'm doing now is going to go through, I'm showing the panoramic 3D, so different screens. Now we're going to look at the panoramic view. It's the same screen, just without the skull. Same screen without this. This has the skull. We're in the panoramic 3D view. I'm just showing some different pictures. Now I'm further in. You can see on the front slicing window, I'm further back now, lingual, and then down a little bit further. This really makes this funny looking with this fish mouth look. It takes a little while to get used to seeing the way the fish mouth looks. These are really funny to me. You know, look at this. This is a slice right through the lateral incisor cuspid region, and it's just a really funny look. But you start to see now, when you're looking at this, I showed you an airway earlier in the tongue position, how much more open this one is compared to the other one. Again, I'm just playing with some radiological views, opening up this coronal view. I just made smaller the oblique view. I opened up the oblique view here, the sagittal. So it's almost good enough to do your cephs if the person's small enough to capture enough information, so this can take the place for a child's for a cephalogram. It's a little harder for an adult with a big head. Again, this is a nice view through the atlas and axis orientation here. Now we're going to start the process for nerve mapping. One of the things that you'll notice, now we're going to be working on the right side of the screen. I go back here. We were in diagnosis here on this right side. Near the bottom it says nerve, implant, and surgical guide. When we go to use the nerve, we click on the nerve and it moves up to the top and basically pulls the menus up. So we're going to be mapping, it says the left nerve. The diameter of the nerve that it's going to pick initially is 1 millimeter. And then we click right here on the nerve point, and that will set your first nerve. As we're going through, you just do a quick double click anytime you want to leave a new nerve spot, and we'll just start scribing it out. Typically, we'll start at the rear area and work our way forward. So I've moved my slicing window back to where I think I want to start, and I start looking around for the mandibular canal. Sometimes it's really blatant, and other times it's a little elusive, as you know. So there's any one of these images you can click into, and it will carry throughout all of them. So you don't have to worry about if I'm clicking this one. If you can see it in one better than the other one, you don't have to see it in all three in order to make your clicks. And that will start scribing out your nerve. So here's adding the nerve point right here. So we click on that, and that's going to be starting us off. There's my first point. You can see I saw the canal right there. And then we'll just move a little further forward. We'll drag the, on the axial view, we'll just move that coming forward, and then tag another one. You can see there's another little stretch now. It's like taking a shrunken up earthworm and making it longer and longer and longer. It's kind of how I think about it. We're just going through now, looking for where the nerve canal is, and you start clicking, making your nerve points, and the computer will connect all the dots when you're all finished. So basically, that's showing up to that point that we've tagged the nerve. I'm going to show you some implant placement. This is the same problems that you can run into a panoramic X-ray head angulations. You run into this. This person's head was tipped much too angularly. It's like when people fall asleep at lectures. It goes down, and that's how this image was captured. You can see this big smile. But nonetheless, you can work with it and make it have some good usable information. So we're going to be going through now how to use the implant aspect of this. The panoramic view, I start with the slicing window out of center, just so I can get the overview of where you want to look. One of this top cursor here that you can't see it unfortunately on the screen. It comes up with a little grid. When you click it, that becomes your mouse. You can just take that click, you can bring it to wherever you want, and that slicing window will jump immediately. So that one, because it's a smaller volume, there's no volume attached to it at first, so it just goes, and then the volume catches up to it a little bit later. It's about a half a second later. So that's a very fast way to do orientation. So it's like that fast from the time that you do it. So we start by orienting yourself to the image that you want. Now we're looking to place an implant. So one of the things that you want to do is see, are you where you want to be? And how do you know that? Well, you're going to start to measure. There's a spot that, for instance, tooth number 4, I want to put an implant in there. So you're going to be measuring the buccolingual width of the bone. It's 11.25 millimeters. Now, one thing, if this appears too small in your window, you can just drag that and expand it by taking the roller mouse. It'll just blow that image up. You can make it huge. And then you use a right mouse click inside the image, and you can move that picture, that now blown up image, anywhere you want inside there. So it really expands everything. Just to point out, he does have two titanium implants here. You can see the scatter is very low from a titanium implant compared to the stainless steel earring that woman had earlier. So we measured the buccolingual dimension. Now I measured the top to bottom dimensions, 23 millimeters. So he's obviously got plenty of bone in those two directions to have an implant. Now the third aspect of it is where buccolingually can that implant be placed? Because that one picture is missing, and that's going to be over here.
Ladies and gentlemen, good morning. This is the captain.
Well, imagine 11,000 feet below us.
Yeah.
Long way to go.
It's in rock bottom.
Yeah. We have about 20 more minutes left. We've got only a couple more slides, but we're going to do some hands-on. I'll show some live things with the software. So the next thing we're going to do is, if you notice over here now on the right, I've opened up the implant menu. I'm going to click on the implant, the little guy here, which opens up this screen. I'm going to say, okay, I want tooth number 4. It's going to ask, how do you want it oriented? I've only used ever vertical. And then it asks for a manufacturer and implant line. So there's a little drop-down button here. I'm showing here a generic implant. It has, like I said, there's about 36 different sizes, shapes, types, and you'll see that here. Maybe you won't. You will on. No, I can't. Sorry. Maybe ahead of myself. Okay. So we can, with the generic implant, you just say how big you want it to be. Apical diameter, occlusal diameter, length. And then it creates it, an electronic version, and you just drop it. You can move it wherever you want. A little hand comes up, and you can move it where you want to. If you already, first off, it'll put it against the alignment of the crosshair, so it's up and down to that. If you don't like the way that is, so it's just dropping it right here. You can see this is the orientation that I want, which is on an angle. It's putting it in straight vertical. A little, your cursor will change, and you can just drag that bottom piece right here. As you can see the orange color right here. It's overlaid more precisely here, but that is an orange color there. You can just take that one little pole and drag it and put it right into the confines of the bone. And then when if you're happy with the way it looks, you click down on this bottom, it says implant aligned, and it will take that, make everything back vertical to the tooth. So it doesn't like to work with an implant that's angled. It'll let you make it angled, but then it doesn't want to stay angled. So you hit implant aligned, and it'll make the implant back vertical again. Okay, now I'm in the implant align mode, and I was mentioning where are we buccolingual in the bone. Right here is the center part of the implant. So you can now take this implant, just clicking on the mouse, and bring it, drag it wherever you want to, and test. You can literally test virtually the orientation of the implant within the bone and every one of the dimensions that's possible. If you want to do some fine tuning on the angulation, you can, so be it, do it. The reason they have this in here, and one of the neat things is that you can order a surgical guide. You would simply take an impression of the arch that you're seeking the implant. You would take this image, export it from that screen that I showed you before. That gets FedExed over to Germany into a laboratory. They will send you back the precise drill path on a plastic stent that you need to take and wear for that orientation, so that you have almost like 100% accuracy in placement of your implants where you're seeking to put it. So the standard of care, because of technology like this, is now becoming much more readily available. It's going to be changing. So if you do place implants and you're not taking advantage of some kind of imaging software, a panoramic X-ray is marginal now if you ever have a problem, because it's now becoming much more readily available. Here's the implant. I moved that over. You can see the position from here. I moved it buccally over here. And we said, okay, now we're done. So it's saying that my diameter occlusally is 4 millimeters, 3.5 at the base, and 12 millimeters long. So there I've got it. It's all ready, set, ready to go. I can, with confidence now, you can do your surgeries. If you're not doing implants, if you're wanting to do bone grafting, you can see how much bone that you've got available, that you don't have available, that you want to bulk up, beef up, whatever adjective you want to have. Okay. This should work. This is the screen. Now, this had been altered by me. So this is the screen. Pretend there's a skull there. A little hand that comes up right at the top that says Edit in 3D. So I'm going to go ahead and just activate it. This should open up now the Galileos software. And I've done this several times, so I know it works. It's going to take a little bit of time. These are very complex programs. They take a lot of data. The file that's exported basically fills one CD, 664 megabytes of information. It's being put onto one CD for one patient. So you can imagine you're going to eat up hard disk space on a regular computer. I mean, it can be fast. we have substituted, while this is loading, basically in our office, we've substituted the panoramic x-ray now by using this exclusively. And there are limitations to both instruments. There's some things I showed you. The one lesion that I had shown you earlier on the lower right second molar, on a panoramic x-ray, that you can see quite plainly. But on the reconstructed image, when it first pops up, you can't see it until you do the that little slicing window that you put into it. Now you can move back and forth throughout. So I have noticed some of the differences in it. There's, as I said, there's goods and there's bads of both kinds of technology. As I mentioned, it's a 14-second scan, and people like that because they're in and out quickly. And in digital, it gives them a lot of peace of mind that they're getting a lower amount of radiation. And compared to a medical CAT scan, that's true. There's 200 individual images that you're blasting people with for brief bits of seconds, and it's still, I think the equivalent is like 7 Panorex films normally that you would take. I'm not hooked up to my database at the office, so it's asking me, it's asking me if I want to use the viewer, which is what a remote computer user would have. They would just have a viewer. Yeah, Paul?
Is that 7 digital Panorex film or 7 standard?
Standard. Yeah, standard panoramics. Film-based. 7 film-based panoramic.
When the guys put it in mine, they told me it was just like doing 2 or 3 digital panels, is what he was telling me.
Well,
it's 1/10 of what you would get from a medical CAT scan.
The thing that I've come to learn, just like Boyd Haley was saying about the government and the FDA and the CDC, I have yet to have one consensus answer when anybody has been asked that question. Any of the trainers in the advanced training, they all have a different answer. And they're all not supposed to be singing from the same sheet music.
Right.
One common answer. No.
So now it's going to load up.
If you can use them to see.
The first volume, this is what takes about 2 minutes. So it's incredible, the technology. We're already having our first upgraded software put in next week. So we've only had it for 4 months. They're trying to make this export feature easier to use for practitioners, which right now it's a little cumbersome. For instance, I've got the software loaded on my little 2 gigabyte cruiser drive, but I can't get it off of it. I don't know how to do it. So I can't make it easy for you right now to be able to do it. So we're still learning about it.
Nick, can I ask a question?
Yeah, Louisa.
You know, we've always been told that there's like a bud or a little remnant of a wisdom tooth that's, you know, that's congenitally absent. And yet I've talked to a lot of dentists that said they've never seen these little buds or congenitally absent areas. Have you seen that in the wisdom tooth area?
No, I have not.
You haven't either, okay. It's a myth.
Okay, so this is how it first comes up. I'm going to do the analysis for your benefit. You open it up, go to Panorama. This is what the screen looks like. We're basically going to be taking, by using this upper, I like to take this yellow line, this orientation line, and put it at the base of the bone where the teeth emerge. So that's where I align that. I look up here on this image and I want, this is the focal trough, so I want, anything that I want to see has got to be inside that thing. The second thing that we do is that we look at the orientation of the head of the condyle, or the upper part of the ramus. So we're going to go to take that yellow gizmo and go higher. We're going to look now at the part of the ramus, and just for orientation. So So that's off a little bit, not very much. I'm going to, just for illustrate, I'm going to illustrate, I'm going to take this and move it, I'm going to rotate it clockwise. Get some orientation. I don't like that, I'm going to go the other way. More like that. Once you get it the way you like it, then you simply say okay. And I'll do this here for you. For a smaller arch, I'm going to come down here and just, the size of the person is critical. You can see what happens with the focal drop. It's going to be what your image is going to have. So that's, I like that size. You can change this then, the thickness of the cuts. Make them much tinier. 150, 125, 150 seems to be the most common for everybody. And then you just work within the size of the individual. Say okay, then it's going to reconstitute it, does it quite quickly, because it's already got the data. Hold on. I find two hands are a lot easier to work with. Is this adequate here?
Yeah.
Okay. So we're going to move the slicing window, and as I just move this, I'm going across the occlusal surfaces of the teeth. You notice as I'm moving the window, there's a little bit of a lag in the windows below. That's a function of your graphics card, and so this actually goes pretty quickly. So I'm moving this fast across to the other side. As you saw, there's a little hesitation on the graphics card. Otherwise, it works pretty well. Here's a view for the lateral set. We've only got, anybody is welcome to play on the laptop throughout the weekend if they'd like to. I'm just doing some highlights. Here's the airway that you can look at. Come and look at, highlight the spine, clivus. Go up here. I lost my thing. Up to where the pituitary gland is and sella. And just work all the way around the mouth. And as you're looking at the large window, you can see the changes that are occurring from an orientation standpoint on the side windows here. So this is what's one of the neat features of this. You're getting real-time feedback information, all three planes simultaneously. This is a window that I like a lot. This axial for the four views of radiology. One of the things I'll regularly do, I'm going to pull from up here. I can just take the crosshair and say I want to put that cursor right there, and bam, it's right there. As soon as you hit the mouse, it goes right where you had it. If I want to move the cursor, I can move the cursor, I'm holding the mouse down and just moving it around and following the airway. This is what I call going down the rabbit hole and looking inside of the airway. Now another function, I'm going to just scroll within the image. I was mentioning this earlier, is that you can get that double arrow. I'm going from one side of the head. If you look at the upper, on the right side, the upper right, that orange plane, it's coming through, just slicing the head.
Nick, when you're doing your laterals, are you able to do a set for ortho?
Yes, that's what I'm saying. As long as the kid's small enough, you get the whole head and all the points that you want. Like nasion is, the biggest one's going to be nasion is often just outside of the image.
The problem we've had is the external meatus, getting that, anything else. Well, we haven't been
Size of the head of the kid. And I don't do too many kids. I don't have
They're
that.
supposed to have that corrected in the new software where they can superimpose it now.
They're gonna get, yeah. Well, this is actually me, so I got a pretty big head. So part of me's outside of the.
You're outside of the focus point.
I'm
that's all.
outside of the image, right? All right. Well, I guess I'm gonna save the last 2 minutes for any questions that people might have. Let you play with the software here. It's lunchtime now. We've got the executive secretary is gonna come up and give us the logistics for the afternoon. And if there aren't any questions, okay?
Okay.
Okay.
The obvious question is if you have something like this, only need PAs or sex or
It depends on what you're
What's the
shooting
question?
for. She asked, if you have this, you don't need any PAs or SEPs. And that's not accurate. These images are good, but you have to also think of what is it that you're looking for, and how often do you want to send it to somebody else for them to be looking at it? Because it's sometimes hard to discern some of the finer detail that you want to in the like a periapical compared to the Galileos.
What we'll do is we'll do this and 4 bite wings, and we'll go through in how Dr. Myers was splitting and taking that along the jaw. Then, real quick, if you could show them when you do go to the pano 3D, and if you could turn down those lights for a second. What I wanted to show you is this area right here, and I don't know if you can see it. When he slides this yellow line across here and there, you'll see a really good image, and then we'll follow it up with a PA if there's a question. But you can get excellent resolution of all of them. But see, he starts here, so he's further back. Now, if you take your arrow pick and put it right here and go back and forth, you'll start seeing this slide back and forth, go in and out on it. There you go. See how this slides? That's orientation within the jaw. So you can get an excellent apex, but then you have to follow it up with a PA.
It's a tool. It's not perfect, but it's really good. And it's really cool. Any other questions? John, Andy?
Cost.
Cost the unit around 175,000, 200.
Depending on the specials.
What if you don't have any kids?
You don't have any kids? Well, then you can buy it right away.
We'll be back here at 1:30. Dawn, you got another announcement?
No, I just want to make sure.